Hello and welcome back to Module 3 of the LNEC program. We are talking about symptom management, and in this video we are going to talk about the respiratory system. Two of the major symptoms we're going to talk about associated with the respiratory system are going to be dyspnea and cough. I really want to draw attention to cough because while it may seem a benign thing, it can cause significant distress and suffering when it is chronic, ongoing, and exacerbated by additional comorbidities. So dyspnea is the awareness of breathing that the individual would describe as difficult. Air hunger, work of breathing, tightness, these are all terms used to describe dyspnea. So dyspnea, it's a subjective experience of difficulty breathing. And that doesn't necessarily mean that there is an obstruction, but the work of breathing, that air hunger, the person is able to bring air in, but they don't feel like they're getting enough. So dyspnea really promotes suffering and also is a major cause of anxiety, fear, and distress. As you can imagine, you feel like you can't breathe, you're going to get very anxious and you can be very fearful. So the most prevalent symptom in patients with things like COPD and CHF is going to be dyspnea. And 50% of patients with AIDS, COPD, and CHF, as well as advanced cancer and renal disease, report dyspnea, especially at the end of life. So breathing can be a conscious or unconscious effort and is used in many spiritual exercises as well, relaxation techniques, mind-body therapies. So this it's really interesting to think about from a philosophical standpoint, this breathing and how connected we are to our breath and how important breath is in different types of spirituality as well as in our daily living. I mean, we take it for granted when we're not having difficulty breathing, but imagine not being able to catch your breath or draw in your breath. So dyspnea is a major symptom to address when caring for patients at the end of life. Dyspnea is very complex and can be caused by multiple pathologies. And as always, it's important to identify the underlying etiology of the symptom so that we can really address it more effectively. So some of the major pulmonary causes include tumor infiltration, aspiration, pleural effusion, superior vena cava syndrome, pneumonia, PE, COPD, thick secretions that can be produced by infection or dehydration, bronchospasms, ascites, and the ascites really, it's when there's diaphragmatic impairment because of that increased pressure in the intra-abdominal cavity created by that additional fluid. Some of the major cardiac diseases include acute MI, CHF, pulmonary edema, pulmonary hypertension, severe anemia, and then really any type of cardiovascular disease can result in dyspnea. Neurological disorders, things like ALS, muscular dystrophy, myasthenia gravis, different cerebrovascular diseases, as well as trauma can cause dyspnea. Other causes include things like anxiety or pain, anemia, ascites, we mentioned different metabolic disorders such as alkalosis. Obesity can cause dyspnea, especially if someone is sleeping on their back. They have that weight of the chest pressing down on their upper airway. Deconditioning, so wasting away from different illnesses or having been on a ventilator can really cause that. Interestingly, feelings of guilt and issues of trust can also cause dyspnea. So think about anxiety. That can really increase the work of breathing and have that person feel like they're not able to draw that breath in. So as we list these different causes, you can see how it's important to identify the underlying etiology, because if you have somebody with a pulmonary condition and you're trying to give them bronchodilators and corticosteroids and different things to decrease their secretions, but really it's anxiety that is the underlying cause of dyspnea. No matter how many pulmonary related interventions you do, you're not going to relieve that dyspnea. So that's why it's important to understand the cause of the symptom in order to effectively address it. And how do you understand or identify the underlying etiology? It, of course, is due to a very thorough assessment. So, a lot of times healthcare providers equate breathlessness with hypoxia, but it's not necessarily going to be caused by hypoxia. Remember, if you have anxiety or the patient has anxiety, that dyspnea is not caused by a pulmonary, cardiac, or neurovascular condition, nor is it caused by hypoxia. So doing that deep assessment using both subjective and objective findings is important in identifying that underlying cause. Treatment for symptoms of dyspnea should always be focused on improving function and quality of life. Remember, we are promoting quality of life, we are not prolonging suffering. The first line treatment for dyspnea is typically an opioid such as morphine, and it should not be avoided due to fear of respiratory depression. Now remember how opioids cause respiratory depression. That's one of the biggest side effects they have. We do not withhold treatment for dyspnea because we fear the patient will stop breathing. And so this is important. Morphine is the first line defense. So morphine is going to be one of the best things that you can give your patient to help with dyspnea. Now, when you are treating your patient with dyspnea using morphine, it is important to know, is the patient opioid naive? Meaning, have they had any introductions to opioids in the past? If they have, that means they can tolerate a higher dose. If they have not, that means that you need to start with a lower dose. So for the opioid naive patient, typically the starting dose of morphine is 0.5 to 1 milligram IV every 1 to 2 hours, with up to 5 to 10 orally every 3 to 4 hours, and 10 milligrams of extended oral release morphine. So there are different ways to titrate it. There are different routes. Oral morphine, the little liquid drops, is really, really helpful in relieving dyspnea as well. And this is great for patients who are dying at home and do not have IV access. There are also non-opioid options for treating dyspnea. Benzodiazepines can be very helpful for refractory dyspnea, especially if opioids or other non-pharmaceutical trials have not been helpful. Lorazepam is really helpful in relieving dyspnea, particularly because it has a short half-life, and so it's not going to linger. So a dose of just 0.25 milligrams PO or sublingual every 4 hours can be very helpful to patients. Always remember, as you're treating dyspnea or any of these symptoms, you have to reassess the patient. So while lorazepam is helpful to many patients in relieving dyspnea, there have been as many as 7 studies showing that using benzodiazepines to treat dyspnea in patients with either advanced cancer or even COPD, they did not find significant benefit from that. So it's important, as you are treating these symptoms, you are reassessing to determine whether or not your goal of symptom relief has been met. Some other helpful treatments of dyspnea are going to be dependent on the underlying etiology. So if infection is present, such as pneumonia or pleuritis, then antibiotics are going to be helpful in treating the underlying infection, which will ultimately relieve the dyspnea. Anticoagulants if a pulmonary embolism is present, obviously. Bronchodilators for bronchospasms or asthma exacerbations. And it's important to remember that these can elevate the heart rate because they are a sympathetomimetic medication. They are stimulating that beta-1 receptor, which is going, they're interacting with that beta-1 receptor, which is going to increase that heart rate. Diuretics are helpful when dyspnea is caused by fluid overload, and corticosteroids can help relieve the inflammation that may be present in the lungs. So again, identify the underlying etiology, treat that, and reassess your patient to see how well it is working. There are also non-pharmacological interventions that are helpful in treating dyspnea. So things like a fan. I'll start with a fan. I cannot tell you how helpful a fan is in relieving those symptoms of dyspnea, especially in patients with COPD. The hospital actually has fans that they stock that are little fans, battery operated, can sit on the tray table or in the bed, and can gently provide that air movement to the patient's face, and that is so helpful in relieving dyspnea. Other things that can be helpful include cognitive behavioral therapies, such as with counseling, different exercises like pursed lip breathing, energy conservation techniques, elevating the head of the bed is often very helpful, just repositioning the patient, helping them sit forward. I actually had a patient last week that I was taking care of who came in with a CHF exacerbation and also had COPD, and he was in fluid overload. So his lungs sounded like he was breathing underwater. He was on BiPAP, 95%. He came in diaphoretic, sweating, and all he wanted to do was sit on the edge of the bed in that tripod position. And so he, as soon as we moved him from the stretcher, he just threw himself onto that edge of the bed and leaned forward so that he could feel like he could breathe a little bit better. So positioning is really, really helpful. You'll notice as you take care of patients who do have COPD or CHF, if they're laying in bed and you go to reposition them and lower the head of the bed, they tend to get a little bit anxious or fidgety and want you to put the head of the bed back up as soon as you can, because elevating the head of the bed is going to relieve those symptoms of dyspnea. Not only will it relieve symptoms of dyspnea, but it will also be very helpful in promoting an open airway, and it helps that fluid to fall deeper back so that it's not right up in the forefront, and it also helps to increase gas exchange. Relaxation techniques can be very helpful, especially if the dyspnea is caused by anxiety. So things like music or just other distractions, having family present. There's a lot of apps that have kind of this visual thing, like one of them is a flower opening and closing, and so the patient watches this, and as the flower opens, they inhale, as they close, they exhale. So that kind of helps them control the rate of their breathing and just get things slowed down and back under control. Now let's talk about coughing. So the same with dyspnea, etiology is going to matter. So there can be numerous causes of coughing. It can be a chemical reason, it can be from inflammation, it can be mechanical stimuli, it can be postnasal drip, allergies, bronchitis, asthma, pleural effusion, GERD, PE, pneumothorax. It can be from an ACE inhibitor. So there are many, many different causes of a cough. So cough, just like dyspnea, it can be very frustrating and debilitating for the patient. It can cause pain, fatigue, insomnia. It can even cause vomiting. So an ongoing cough is also a constant reminder of the evolving disease process. And this can further cause social isolation, because frequently, especially in today's climate with COVID, especially, in 2020, someone sneezed or coughed and you looked at them and moved away as quickly as you could. But still, even 2 years later, it continues to be that way. Coughing is something you don't do in public anymore because you don't know if you're contagious, and so that can be another reason that patients become isolated. So there are multiple ways to treat coughs. The biggest one, treat the underlying cause, and then there are pharmacological suppressants for cough. So things like opioids work, but obviously they're not going to be ideal for long-term treatment. Let's see, things like benzotrate, mucinex, if it's from thick secretions, anticholinergics, for high volume secretions, but really it's important to identify the underlying cause.